So with that, I appreciate the opportunity to be with you today.
Thank you very much. Move on to David Lown, MD, Chief Medical Officer, Safety Net Institute. Good afternoon.
Thank you, Senator Hernandez, and the other members of the committee for allowing us to speak on this issue that is at the heart of the mission of the organizations that I work for and represent. So, as mentioned, I am the Chief Medical Officer for the California Healthcare Safety Net Institute, which is the performance improvement arm of the California Association of Public Hospitals and Health Systems. These are the county-owned and operated hospitals and clinics throughout the state, as well as the 5 University of California medical centers. So the 3 things I want to touch on today are to talk a little bit about the populations that are served by our member organizations, talk a little bit about the successes and work we've done to date to address disparities, and then lastly, talk a little bit about a next level of work, in particular enhancing standardized, systemic work, which is, echoes a lot of what has been said by other folks here today. So first of all, our members serve just under 3 million patients a year, the majority of whom are, vast majority are under 200% federal poverty level. We provide 40% of all hospital care to the state's uninsured, and over 2/3 of our patients are from communities of color. And with that, additionally, the majority of our members, in order to serve our patients well, participate in the Healthcare Interpreters Network, which provides virtual interpretation services for 16 preference languages throughout California. So a little bit on work we've done to date to address disparities. And I'd say the first I want to touch on is the Low-Income Health Program, also known as the LIP, or LIHP, which allowed California to enroll 700,000 individuals in local coverage programs and prepare them for the smooth transition to Medi-Cal with the expansion of, when Medi-Cal expansion took effect. So our public health systems played a significant role in the implementation of the LIP, and 73% of those 700,000 enrollees were actually in counties with a county-owned and operated health system. The significant challenge for our populations is the lack of continuity of coverage. And the LIP is the first statewide effort that we've engaged in to address continuity and thus begin to address disparities. And the LIP really helped public health systems enroll people into medical homes so that they could get the primary care that they really needed. The second initiative is the Delivery System Reform Incentive Program, also known as the DSRIP, not the greatest name, but which is the Pay for Performance program under the current 1115 Medicaid waiver. The DSRIP provided public healthcare systems the opportunity to earn financial incentives, financial payments for achieving ambitious milestones that demonstrate system-wide improvements in the public health system care delivery for Medi-Cal and uninsured patients that they serve. I believe you have a brief on the topic that we wrote called Leading the Way. It's also available on our website. So our system is engaged in hundreds of improvement projects under the DSRIP that improve the care for all the patients, underserved populations that they serve. One example of a project was integration of behavioral health, where members engaged in integrating and co-locating behavioral health services into primary care services so a patient could get both services, medical and behavioral, at one site, implementing telepsychiatric services also to be able to expand access to mental health. Just one example, there are many, many, many more around care transitions from hospital back to home or primary care, care coordination, complex care management, ED navigators, as we talked about it before, the importance of helping newly covered patients who are high utilizers of the emergency department back into primary care, how to use that system and access the care they needed. Just one example. Other initiatives under the DSRIP, we actually had a couple, I would say, specific disparity reduction focused initiatives. One around enhancing the interpretive services and culturally competent care provided by our systems, in particular expanding the use of virtual interpretive services for our populations. At some sites, this translated to over 8,000 interpreter encounters every month by using this service. So fantastic. The other was around race, ethnicity, and preferred language data. And this included a number of things, but one big point, which I think we haven't touched on today, was is actually getting staff buy-in and training of staff to more accurately collect the data in a way that truly reflects what the patients are bringing rather than what staff are perceiving as the responses to these various elements. Also establishing processes for universal capture of this data in a granular and standardized structured manner in the electronic health record, and linking that to quality data. One item of note that a number of our members mentioned is that while most are moving towards electronic health records, the electronic health record vendors are only required to have essentially the OMB categories, the standard roll-up categories for race, ethnicity, and language, and do not have the ability to capture the more granular data, which leaves individual organizations with the need to develop that and try and get their electronic health record vendors to do that on an individual basis, which creates a lack of standardization across the field. Some other targeted interventions that our organizations have been involved in outside of the DSRIP and the waiver have been things such as mobile asthma clinics in San Bernardino and in Los Angeles County, Alameda Health Systems implementation of a health equity council, which I think is fantastic, focusing both on the collection of data, but also the importance of health equity. It's from a leadership, from the CEO standpoint down to frontline staff. Santa Clara County's Black Infant Health Program and their Healthy Lifestyle Clinic in East San Jose, a family-focused childhood obesity initiative, which has had great success. And then Los Angeles' Mama's Neighborhood, also a Black Infant Health Program. And lastly, Natividad Medical Center's Indigenous Interpreting Plus services, providing, well, exactly as it says, indigenous interpretation for the populations they cover. So lastly, I want to touch on sort of next level of work. So in addition to the various initiatives that I just mentioned, a lot of the work that our organizations have done have been, I'd say, more grassroots driven, based on the clinical and community experience and intuition. And we really want to complement those efforts with a more systematic and data-driven initiatives. So as we've made strides, public health systems have made strides in expanding coverage and improvements in our systems of care. We really want to now also enhance the systematic collection of data. This is obviously a theme across all the folks who have spoken today, including working on staff buy-in and training for a more accurate collection of race, ethnicity, language, sexual orientation, gender identity, and also social determinants of health, including education, housing, social isolation, which are so important and markers of increased risk for disease. Being able to collect that more standardized granular data for improved actionability of the data, implementation of routine system-wide data collection processes, and developing processes to use this data to identify data disparities in services and quality on a routine basis as part of regular reporting efforts. And then, of course, to develop standard processes for developing and implementing interventions to reduce those disparities. Also, we want to build many of these processes into the next Medi-Cal waiver. As Sarah mentioned, their efforts are already ongoing, and we want to try and do that in a much more robust manner. Certainly, having standard system-wide data collection allows greater opportunities to develop structured, targeted interventions for issues that may already be commonly understood to be of importance in and by the community. Lastly, I just want to give just an example of how this has affected patients that I've cared for. A patient of mine several years ago, Mr. S., was a gentleman of Mayan descent from Guatemala who, after a little while, we figured out spoke Quiche. So Quiche is a Mayan dialect, and we didn't have any Quiche interpreters at the time. And we were, although able to work through his Spanish, a little bit of Spanish, to figure out that he had diabetes. But finding the appropriate interpreter services, finding diabetes information in Quiche, and certainly also finding other Quiche-speaking peers was quite challenging. And what we needed to provide the best care for Mr. S. was really routine collection of this granular ethnicity and language data, as well as having the indigenous interpreter services that some of our other members are working on, and access to language concordant health education information. And with these kinds of services routinely in place, we'll certainly be able to better care for the diverse spectrum of people that we have the honor to serve. Thank you.
Thank you. We'll move on to Robert Moore, Chief Medical Officer, Partnership Health Plan of California.
Great, thank you, Senator Hernandez. It's with great humility that I follow the distinguished speakers that have discussed many aspects of defining, thinking about measuring and addressing disparities in healthcare and health status. I'm the Chief Medical Officer at Partnership Health Plan, a family physician, and I'm going to talk a little bit about the role of managed care plans in addressing disparities in healthcare and health status. I've devoted my career to serving the vulnerable populations in California, first as a family physician at Community Health Clinic Olay, a federally qualified health center, serving low-income, predominantly Latino and largely Spanish-speaking population in Napa. More recently at Partnership Health Plan, a county-organized health system and a Medi-Cal managed care plan serving 523,000 members in 14 Northern California counties. In that time, I've learned a lot about health disparities, both through formal training, but also through some on-the-ground experience, analyzing data and caring for a diverse population. Let me give an example from 2007. Like Dr. Lown, I think an example really helps. At that time, the rate of newborns breastfeeding at 2 months of age was about 60%, both for Hispanic mothers and non-Hispanic mothers in the city of Napa. But in St. Helena, the rate was below 30% for Hispanic, mostly Spanish-speaking mothers, compared to 60% for non-Hispanic mothers. The demographics of these communities were the same. The cause of the disparity, the nurses in the hospital at St. Helena genuinely believed that Hispanic mothers didn't like to breastfeed, and so they started bottle feeding the Hispanic babies in the hospital. This is not unique to this hospital. The solution was to provide the data to the nursing leadership, educate the nursing staff, and monitor the change. The data was there actually before then, but the key to taking that data that existed was an intervention that occurred by a community-wide perinatal collaborative work group. So data alone does not drive change. It really takes some kind of work group to make that data take action. Medi-Cal health plans are mandated by DHCS contracts to conduct certain data analyses and perform certain activities related to disparities, which Sarah outlined, and I've also listed in my written remarks, which I won't go through, but were distributed to you all. In addition, further data analysis and collection, as has been discussed, will be helpful, and I have some suggestions which I won't go through either. But I wanted to talk about the elimination of disparities that really won't happen first by writing some additional contract requirements for the health plan, and secondly, just getting data by itself is not going to eliminate disparities either. Any organization seeking to make a significant impact on disparity of outcomes needs to have strong leadership and a systematic focus on improvement of outcomes. Again, legislating new contract requirements will not do this. For the last 15 years or so, the non-for-profit health plans of California are leading efforts to improve outcomes. They've increasingly expanded their horizons from providing cost-effective healthcare delivery system to a more community-wide sphere of influence, including supporting community-wide prevention and wellness efforts like Kaiser's Thrive campaign, funding community-based organizations to provide care navigation, case management services that address underlying causes of poor health, known as the social determinants, and most importantly, collaborating with community coalitions and public health agencies to make larger scale community-wide changes. One example is Partnership Health Plan has a multi-county, multi-stakeholder initiative to reduce opioid overuse, overdose deaths, and neonatal drug withdrawal. The other way that major impacts on health status can come is from a focused public health, public policy intervention, such as tobacco tax, seatbelt laws, child safety seats are examples. And lastly, the other way major changes can be made is through quality improvement advocacy organizations, such as the Institute for Healthcare Improvement's 1 Million Lives campaign, or the reduction in maternal mortality achieved very rapidly within a couple of years by the California Maternal Quality Care Collaborative. It is these major improvements in overall health status that have a major enduring impact on disparities. So what can the state of California do to support health plans and our provider partners in reducing disparities? I have 3 specific recommendations for the committee to consider. The first, ensure that the financing and structure of the Medi-Cal program itself is sufficient to prevent disparities due to having Medi-Cal, as opposed to commercial insurance. The state and the Medi-Cal managed care plans are responsible for the quality of care, but not in the areas of dental, alcohol, and other drug use disorders and the serious and persistent mental illness. If this care is inadequate, a disparity exists due to the inadequacy of the coverage itself. And secondly, in this point, through its oversight responsibility, DHCS monitors and evaluates the quality of care provided through Medi-Cal managed care plans. And this oversight must ensure equitable care for the entire Medi-Cal population, including beneficiaries who select a for-profit insurance plan to cover them. Second recommendation is to create a recognition program to showcase health plans, providers, or community coalitions that do have a major improvements in health disparities or the health status of a large vulnerable population. And I do take issue, I would differ with some of the folks who've mentioned a pay-for-performance for this. I think given the uneven state of health disparities, data accuracy and collection, a pay-for-performance program for health disparities is really not feasible at this time. And the third is to sponsor high-quality training of staff at health plans, health centers, and public hospitals on the theoretical framework for understanding health disparities work, considering partnering with the California Healthcare Foundation for these efforts. My written testimony includes some additional material. I do want to highlight, though, on the last page, additional data needs, because it was brought up by Dr. Lown. He talked about the more detailed data that really does need to be systematically collected at the primary care level. That's the only place that data is going to be accurate. The Institute of Medicine released a report last year called Capturing the Social and Behavioral Domains in Electronic Health Records that has very specific recommendations for data elements to be collected. But how can California impact that? Because it is, after all, this meaningful use is federal. Well, the California legislature, or DHCS, may consider making some of this data collection a condition for doing the health center alternative payment methodology pilots. To lay the groundwork for capturing this data and really showing the impact on disparities in that payment methodology. And of course, the supporting health information exchange efforts, as Dr. Lown implied, is absolutely critical for this to be rolled up together. And lastly, another ask that relates to the state is linking vital statistics data with Medi-Cal enrollees to allow analysis of outcomes by health plans. Right now, we do not have access to birth and death data, and it's really hard to analyze significant outcomes without that. So I'll be happy to entertain any questions about what the health plan is working on.
Thank you very much. Senator Chavez, you had a question?
This has really been a very informative hearing the past couple hours for me. Very impressed with all the data we're trying to capture. Very impressed with yours. I like why we're doing this issue about, quality of life. One of the things I was looking at, I was just wondering, because I'd been involved in some projects before on trying to manage systems. And I guess this will go to you, Mr. Lee. I said, how much, from your perspective, managers, how much is it going to cost to put the system in with software, hardware, training, management? How much is that time invested? How much is that? If you had 100% window for care, is this one like only 1% of the cost, or is this 10%, or what? How much is it going to cost to do this?
I hazard to get into this. Some of my colleagues who actually run health plans and are at the provider level are more appropriate, but I think that having information to support the delivery of care is a small slice of what the entire cost of care is. And without having that, we can't deliver better care. So I don't know the specific slice, but it really is an issue of without having data to understand where to focus, what the problems are, we can't improve. So I don't know, is it 2%? I mean, you look at the overall healthcare dollars, an electronic health record that is well structured is a tiny portion of what is spent overall in the healthcare dollars. So,
yeah, I talked to my son, who's a doctor, and he telling me that the time that he's used to spend doing with the patient, now that he's going through a 15-page paper, is non-value added. You can hire people to do that. I'm just wondering. So, maybe he has a different perspective than you. Any of you others want to take a stab at this? How much it's going to cost?
So Sarah Brooks with DHCS, I think, and I would agree with Peter Lee in that we don't have a dollar amount. Obviously it would cost money, but I think that we would argue that in the long run there would be savings from providing better quality care and from avoiding emergency room usage that's not necessary, inpatient stays that are not necessary, decreasing the number of people with diabetes and other chronic conditions.
You know, in 1974, the end of the Vietnam War, the military decided to go to the Chevy model, GM model, Ford model, and manage all our motor transport fleet. And so they made this huge computer thing, and they took a bunch of guys. I was one of the young second lieutenants that went away to school to Georgia and sat there for 6 weeks and learned how to work this database and figure out how many tires I was going to use and how much gas and maintenance and miles and weights. And this way we had fleets on the East Coast, West Coast, Pacific, and we could float these around. And we had this whole life cycle management system from the time it came to the time it went away. And 15 years later, I was watching it, and there was a gunnery sergeant that had a board on his desk, and he'd just write down the truck was up or down. Because it was so much information, it wasn't all valued. I mean, it was just like huge. And so since that experience, I always watch systems, and I'm wondering, systems are best when they're some way able to suck the data without requiring a person. Because if you require a person to push a deal, the button, or say, yeah, this, that, and that, and that, and that, pretty soon they start pencil whipping it. That's a military term. And don't do anything. And so I'll be watching this with interest, see if it's, I guess I get to be another 8, 9 years. I guess ask a question, say, how did that anything work? No. Thank you.
Any other comments, questions? Assemblymember Wood.
Yeah, I have a couple questions. First one for Sarah from DHCS. You mentioned early on in your presentation, you talked about monitoring like appeals, and can you kind of walk through that again for me? Because I wanted, there's something you said that I want to grab.
Sure. So it was just talking a little bit about some of our recent efforts related to data analysis. We did recently standardize our collection of grievances and appeals data from the health plan. So previously, we received the data quarterly, but it was in different formats. And so it wasn't really it took a lot of effort for us to consistently look across health plans in terms of what was happening, but we also didn't have the ability to drill down into kind of that beneficiary-specific level. So now the health plans actually submit beneficiary-specific information to us, which has much more detail about what the grievance and appeal was filed for, and then we're able to take that data and stratify it and look at what's happening in a certain race or ethnicity, by age, in a geographic area. So we can really look at, are there specific areas within a health plan or across health plans that need to be addressed, and we can work with the health plans then to ameliorate those issues.
So you're gathering that information from the plans themselves?
Correct.
Okay. Is there any process by which providers can have input on that to cross-tabulate? And the reason I ask is I've heard anecdotally that there are denials of authorizations from some plans for certain procedures and things, and providers are a little frustrated by that. So I'm curious: is there a process by which providers can be engaged in the process so that basically to know that the data is correct?
I think that's an excellent question. Definitely providers can file with the plan as well, and so that information comes to us also. So even though I talked about the beneficiaries, we get provider information as well from the health plans. But I think you're asking about perhaps did maybe a beneficiary not file a grievance for something, or did that not make it into the data that we received? We haven't explored that, but definitely are working closely with our providers in terms of gathering information to better understand how they're working with our health plans. And the other thing I would just mention is that we are looking now at authorizations, because you mentioned authorizations specifically, just looking at timeliness of approvals and denials, or if they're being deferred for additional information timely, but also looking at whether or not the plans are using the appropriate utilization criteria to determine if they should approve or deny them.
Okay, I guess part of what I've heard is that there are certain procedures that seem to be, at least in some areas, routinely denied.
Okay.
So I'm for services that should be covered.
And I can address just from the front lines of the health plan. Whenever there's a member grievance, we always call the provider to, if the grievance team is the advocate for the member, And so their job is to try to resolve that issue. And so they contact the provider they look at what the reason for the denial was. And often it's because a provider didn't submit information. Sometimes it's for medical necessity, but sometimes it's because they didn't justify it, and it was justified. And so there's a close communication with that provider as part of the grievance process.
And are there other appeal processes beyond that then? Department of Insurance or managed healthcare?
Yeah, certainly, providers can go to the Department of Managed Healthcare. There's a state fair hearings and an independent medical review process for beneficiaries through Department of Social Services and DMHC. But also they can email me. Maybe I shouldn't say that right now, but I frequently receive emails and I'm happy to look into
As long
things
as it's not on your personal email account.
Right, no. I'm staying away from that. But definitely, if you do have providers that have concerns, I would encourage you to ask them to email me, and I'm happy to follow up and talk with them about their concerns.
Well, I guess the bottom line, I just would like to be sure that it all kind of balances up at the end of the day, that if there are appeals, that they're accounted for and the numbers all add up.
Yeah, I mean, the other thing I would just note is that DHCS now is auditing our health plans annually through our audits and investigations area at the Department of Healthcare Services, and we work in coordination with the Department of Managed Healthcare, who goes out triannually to do medical surveys. And that is a component that ANI does look at through their medical audit. In follow-up to the report that we might get from ANI that might say, for example, to your point, that a plan is disapproving certain authorizations that they shouldn't be, then we work with the plan on a corrective action plan, and they have to actually demonstrate to us that they've come into compliance, and it's not just, this is what we're going to do. They have to actually show us that they've done it. And so definitely are working to continue to strengthen our efforts around monitoring the health plans and working with them to provide technical assistance when they need to better have better support in terms of implementing the program. Thank you.
And I had a second question. That was actually for Mr. Lee, and that just goes to, I'm just curious, obviously we know that people are re-enrolling now for Cover California. Is there any data collected from anybody regarding, are the plans meeting expectations? So are people, especially with people who have never encountered insurance before, are they actually getting what they think they're getting? Do they understand the product appropriately? And is there a utilization appropriate as you might expect for the general population, or are we getting overutilization? Or in some cases, I know certain populations will underutilize and wait till the very last minute to actually get care. I'm sorry, I threw like 5 questions.
There was at least a few in there. But first on
I've got them written down too. So
first, we're working right now with a national partnership to have what will be a standardized survey, not just in California, but across the nation, to see what are consumers' experiences in health plans through exchanges. And so, did they understand it? Did they think they got, access to care on a timely basis? This is something that is standardized right now in terms of health plan surveying, but to understand for those that are in exchange plans, what was their experience? Did they knew what they got? Did they get access to care when they thought they wanted to, et cetera? And so that's a survey process they're actually in the process of piloting right now, and it's going to be annual starting next year on a regular basis. We'll be able to see that, but we're piloting that right now. In terms of utilization, this really goes to the point of having our clinical analytics capacity. So we can actually say, how many visits should you be getting? And what's the right number? Is it too much or too little, et cetera? And it's really about right care at the right time, and see, it's not a particular, some care can be too much. Some can be too little, but the issue is, are we seeing differences? And this is the question about collecting data is not cheap, but it's a lot cheaper than not getting people the right care at the right time. And understanding what is happening by ethnicity, by education, by language is the key thing I think you're hearing across all these panels that we need to get to.